Dr. Hayes.
Hi,
How are you?
I'm great. How are you?
I'm good. I felt like I should wear my glasses
Glasses.
so we can look like twins. Hi, Carol Bearsager. Anyway, I'm so happy to see you, so happy to have you, and so many people. Can I call you Mary Claire or
Mhm.
should I call you Dr. Haver?
Absolutely. Mary Claire is fine. That's how most people know me.
Anyway, so many people, Mary Claire, have questions about
Mhm.
menopause related things, about hormone replacement therapy. And I really want, I feel so lucky I have access to intelligent, smart experts like yourself. And I'm thrilled that I can ask questions and communicate people's concerns to you. And you can help people deal with sort of these difficult moments in their lives. I'm just going to turn off comments. You guys, if you have additional questions, my team gathered some before we got on this IG Live, but feel free to add questions in the question section. Well, first of all, I mean, I know a lot of people who follow you know all about you, Mary Claire, but in case some of my followers don't really know your background, can you tell us a little bit about yourself and how you
Sure.
found yourself in sort of the
Passion. Yeah.
epicenter of the menopause conversation?
So it's kind of a happy accident. So my name is Mary Claire Haver. I'm a board certified OB-GYN, and forever I was a generalist at a big academic institution. I ran the residency program, I taught medical students, and I took care of all of the faculty and the local people who lived in our town. And I was really happy doing that job for a long time and felt like that would be my life forever. And then I went through menopause and really had a rough time of it. Had, hot flashes, body aches, which I didn't understand were related to menopause at the time, and difficulty sleeping, depression, mental health changes, and weight gain. And so really got interested as to, I knew about hot flashes, but I didn't understand the body composition changes and all the other changes that were happening in my body. So I started doing a lot of research in nutrition and menopause and inflammation, and kept finding all of these new articles that were coming out, and just got really excited about it. Started talking about it on social media, and like the world for me kind of exploded.
I
The
think
more I would.
I think it showed this vacuum when it came
Mhm.
to important, helpful information. And part of it is in medical school, and you and I have talked about this briefly before, in medical school, you don't really, first of all, women's health issues are marginalized in general when it comes to medical research. They just started to become mandated to be included in clinical
Mhm.
trials in 1993, which is sort of hard to believe. Female mouse models, I understand, were just started to be used in what, 2016 or
Yeah.
something? And
Even
I guess,
today, like only 1 in 5 animal models are female.
and,
When you're looking at like cardiovascular disease and diabetes, things that affect both genders.
and it's usually the prototypical example of a patient is usually a white male in his 30s, right?
Yes. So the health system was kind of based in the US and in most of Europe was based around the average white male. And this was because women were pregnant or could be pregnant and were difficult to study. And they just assumed that men and women, other than their reproductive organs, were basically the same. And it turns out, and you can kind of see that, being reasonable until you don't, because what happens is as we age as females, we spend 20% of our lives in poor health than our male counterparts. The medications don't work as well. We're more likely to die of a heart attack. In the first year after your first one, we have much poorer health outcomes. Our lifespan's a little bit longer, but our health span is terrible compared to men. And that's kind of, where my menopause journey has taken me is, what am I going to do for the next 30 years? I don't want to end up in a nursing home if I can avoid it. I don't want to have dementia if I can avoid it. I don't want to have cardiovascular disease, and these things are preventable now, or osteoporosis. And so the bigger conversation of menopause is becoming this last 30 years of our life. And how are we going to optimize our health, and what changes need to happen on a legislative level, on a medical education level, to guarantee that
And I think
happens.
it's interesting. I remember you said to me, there's a whole generation of women who are not willing to accept the status quo. Like there's
Mhm.
nothing you can do. It's a natural part of aging. You're just going to have to deal with it. And as you said, women are living longer, but they're not necessarily living well. Part of this is, I think, grounded in hormone replacement therapy. There was a New York Times magazine cover story probably over a year ago that I think was one of the most shared articles in the New York Times
History.
for, in years. And basically, it showed that there was a flaw in this study. It was stopped prematurely, and it was misinterpreted.
Right.
Can you talk about that women's health? I remember I was on the Today Show and I was covering that story.
Yeah. So the I was a resident. I was the chief resident when in 2002 when the study preliminary findings were released that like set the world on fire, and so it was a great study. It's a great data set. So let me say that, it's 37,000 patients. It was a randomized controlled study, which is the gold standard in healthcare. And it was set up to determine if hormone replacement therapy, which the observational studies were showing, would actually be protective for cardiovascular disease, which we kind of already knew. But because at the time, women who got hormone therapy tended to be healthier and wealthier. Some researchers felt that that was an artifact of patient selection. So in order to prove it, you have to randomize and control the data set. So they did that. The patients only received two medications. One was Premarin, Premarin alone if they had had a hysterectomy, or Prem-Pro, which had the extra progestin in it, if they still had their uteruses to protect the lining of the uterus. Important thing to remember, the average age of the study was 63 years old. Okay, because the end data point ultimately was heart disease. So they had to start older because it's so expensive to run these studies year after year. So they started with an older data set. And within about, I think, 3 years in the progestin and estrogen arm, they found a very, very, very slight increased risk of breast cancer. In the estrogen only arm, they did not, and they continued those women for another 3 years in the study. They actually had a 30% decreased risk. So, but the headlines read, as you remember well, I remember well, it kind of blew up, but this is pre-internet. It really went viral back in the day. It was
Yeah.
the #1 medical news story of 2002. Estrogen causes breast cancer. That's where the misinterpretation is. And so that kind of stopped all clinically meaningful education around menopause outside of how to stop a hot flash or osteoporosis. It stopped, 80% of HRT prescriptions went in the trash. Women were terrified, and the legacy left behind from how that information was disseminated has just changed the face of medicine for women's health for a generation. And, there's been multiple articles where they reevaluated the data, went back, the same authors actually, and walked back so many of the findings. And, the risk of breast cancer was grossly overblown.
It was
And,
very, very slight,
very,
right?
very, very, very slight. So for a patient who's low risk, the benefits will probably outweigh the risks, especially in the younger generation. So that information was not getting propagated. So like you talked about education, I maybe had 1 hour in medical school where they just casually mentioned menopause. And in my 4-year OBGYN curriculum, okay, I learned beautiful, massively important things. But I maybe had 6 hours total of a few lectures on menopause. We had no menopause clinics. We never talked about anything out of the breast and uterus. Like, we were charged with the health of women. We are women's health providers. And we did not talk about much outside of hot flashes, night sweats, and osteoporosis. No discussion on cardiovascular disease risk or, menopause's involvement in the acceleration of those diseases. And so, here I am post-training, teaching residents, in charge of curriculum, learning all these things because I'm digging. I'm going outside of what's required for me to learn because I'm so curious and I don't understand what's happening to my body. And my mind is blown. The information is there and it's not being propagated or taught. And that's where my passion began.
And it seems to me, Mary Claire, that there is a whole reevaluation of hormone replacement therapy,
Mm-hmm.
and that now younger women going through menopause are really being. I mean, this is being
Mm-hmm.
discussed much, much
And
more. And
they're educating themselves, and so they're
yeah,
coming in to begin the conversation for themselves, which is really the new menopause, right? It's not like fixing something once it's broken. It's teaching women that, yes, this is the natural phase of life, but let's learn about it. Let's learn, look at your family history. Let's look at all the things and let's start making intervention plans so that you can live as long and as healthy forever. And hormone therapy for probably the majority of patients can be a really important part of
Yeah,
that.
and if this study had not been misreported, what kind of progress do you think might have been made in the 20 years? I guess this was in the early
Yeah,
90s when the Women's Health
I,
Study at the National Institutes of Health under Bernadine Healy.
yeah.
I remember it so well. If it hadn't been stopped
So
prematurely
the
and
neurologists
missing,
think we'd have much lower dementia than we do right now, in the people getting dementia today. So these are the people who missed the boat for HRT benefits. So we'd have lower dementia, probably 50% less osteoporosis and
how,
osteoporotic
how much
fracture, and
less?
50.
50. Wow.
50% less osteoporotic fractures, right?
Yeah.
We would have, when they looked at the WHI, this is from the WHI, the younger patients. So the average age of 63, but we had younger patients. The patients who were between 50 and 60, starting the HRT within 10 years of their menopause, had a 50% year by year decrease in cardiovascular deaths. So that's kind of where we're going to have to play catch up, and where had that, misinformation, it's a great data set and the researchers worked really hard on this, but, had that not happened, I think right now women would be living a better health span and a little bit more lifespan, probably 2 more years.
Well, let's talk about HRT. I
Mhm.
mean, now what is the standard of care in terms of helping menopausal women or perimenopausal women
Mhm.
think about using hormone replacement
Sure.
therapy? I remember there were bioidenticals. I think
Mhm.
Suzanne Summers kind of did all that stuff.
Just,
Um, and I think women are really confused about it. By the way, I can't believe how many questions we got for you. So I'm not going to go on and on with the questions I want to ask because I want to get to a lot of people's questions. But
Mhm.
what is the sort of the what would you tell someone who came into your office and said, Marie Claire, I'm starting to feel perimenopausal,
Mhm.
I'm exhausted, I'm having hot flashes, I feel like I have a little brain fog,
Yeah.
but I'm only 43 and my mom went through menopause when she was 56.
So, here's one problem. We don't have a great blood test to determine perimenopause. There's nothing available. There's not a great urine saliva test that's going to be clear, because let me walk your listeners through, or your followers through this. In regular premenopause, right, you're having monthly periods in a healthy patient. We have a normal ebb and flow of hormones coming out of the ovary. Estrogen surges in the middle. We all kind of know this from trying to get pregnant, and then progesterone comes in the last half of the cycle. That's all driven by the brain. Okay, so the brain is sending out chemical signals, hormones called GnRH and LH and FSH, that are the FSH and LH are talking to the ovary saying, okay, let's ovulate, because the estrogen levels naturally get low after ovulation. And so when we're born with all of our eggs, we start running out in perimenopause. We reach a critical threshold in our egg level supply where those signals don't work as well. And we need more signals. So the hypothalamus is looking for that estrogen. It's not coming fast enough. So it's saying, okay, hey, give me a bigger LH FSH surge. So we see these bigger bumps in FSH to make that ovulation happen. Ovulation becomes delayed. That leads to irregular periods, sometimes heavy periods, sometimes light periods. And then those hormone signals, which used to look like an EKG each month, now become very, very chaotic. So there's not a great one-time blood test. There's a few urine tests on the market that are meh, might give you some, but there's a great scoring system called the Green scoring system. And it was developed in the 90s and
What's it
revised in
called? Sorry.
the Green scoring system. That's what I use in clinic. I talk to my patients. I do blood work to rule out other causes. If there's any suspicion of full menopause, I'm going to go ahead and check some hormone levels. And then I make the diagnosis usually clinically based on her symptoms. And then we begin a discussion around, could hormone therapy be helpful here for you? And I start treating. Now, postmenopause is easy. We got great blood tests for postmenopause, or if you've gone a year without your period, that's the definition if you're over the age of 45. So what's happening though is we've had zero education on perimenopause. Nothing on treatment. All of that I know about how to treat perimenopause is the Menopause Brain Trust getting together, all my friends in the menopause world, talking about what they're doing clinically, what's working for their patients. There's just so little data out there. So, really it is clinical expert, on how we're treating perimenopause. And our group chat is great because we're always talking about patients and what did you do here and what's working for her. So it's a great, community to have.
So what are the common symptoms for perimenopause, or does it vary from patient to
It
patient?
really varies. So one of the things, usually 90% of us will have cycle irregularity, 85% will have hot flashes, but typically there's a great article that just came out. Something's not right. The patient will know she doesn't feel like herself. And most of that is mental health changes. So remember those chaotic hormone levels in peri, and then they
Right.
bottom out in postmenopause. The brain hates chaos. And so you start wreaking havoc on our neurotransmitters, on dopamine and serotonin, which are really dependent on these levels of hormones. And so once we lose, we have an ebb and flow of those same neurotransmitters when we ovulate, and that's why we have PMS and feel different ways throughout the cycle. Now we've taken away any regularity and the brain goes crazy. So we see about a 40% increase in mental health disorders in the perimenopause transition, as well as that's when the brain fog begins. But remember, estrogen receptors are in almost every organ system of our body. Some of my patients will come in with bloating. Musculoskeletal pain will affect 60 to 80% of us. Frozen shoulder, hip pain, joint pain, back pain, no injury, just kind of woke up with it and it's not going away,
I have that.
headaches,
I just,
migraines.
I just took, I mean, I'm way past peri and menopause, but I have terrible joint pain, which is maybe specific to what my situation is with aromatase inhibitors. That's another subject altogether. I tried a cold plunge for the first time, and I have to say, maybe it's psychological, but I feel like it really helped me.
Well, for patients like you, there is a lot of research coming out now on who are on aromatase inhibitors or on, have a history that precludes them from being a candidate for estrogen therapy. So there's great SERMs, the selective estrogen receptor modulators, that are coming out that kind of spare the breast and spare the uterus, but then will deliver, the right estrogen to the part of your body that needs it.
Really?
So I
Are
think
those available now?
no,
Because
there's a
I need.
couple. So basidoxifene. So there's a medication called on the market called Duovy, and some of your listeners might be on it. And it is HRT, but instead of a progestin, it has basidoxifene, which is kind of like tamoxifen. Okay,
Oh,
it's a SERM, so it binds and blocks and downregulates the receptors in the breast and uterus, and then you give an estrogen with it. So this is what's in the Duovy. Dua means two, so it's Premarin plus the basidoxifene. And so patients who've had like stage 1 cancers, or who are kind of like gray area, should she get HRT or not? This is some, because of worries of tumors, this is a great option. So there's more, I think, coming down the development pipe since we're talking about
yeah.
this and it's now being medically recognized, and not everyone is a candidate for estrogen. So I'm really excited about the
I'm
research coming out.
I'm excited too, but it's not about me, and we'll talk about me in another time. Sorry, everyone. I just couldn't resist the opportunity to ask Mary Claire about that. All right. So I know that you did also the Galveston diet
Mhm,
as part of it that's really focuses on protein and fiber,
mhm,
which you think is really important
mhm.
when you're perimenopausal, menopausal, or postmenopausal, honestly, because I never had a stomach, and I've got like this big belly now. It's really frustrating for me, and I try, but I do eat a lot of cookies too. But anyway, tell me, what should
So
people be eating who are going through any of these stages?
sure. It really is a wake up call. About 85% of us will notice a dramatic difference in how our clothes fit
And
and
weight distribution.
weight distribution. So in medicine, we call it body composition changes. So we start losing muscle due to aging and the loss of the hormones in menopause. So we lose muscle much faster. It's harder to gain muscle, but it's possible. You have to just work hard at it. And so in a premenopausal woman, so Katie at 35, right?
Right.
Average body fat percent that is visceral, that intra-abdominal fat, is 7%. Okay. Just don't change anything in your diet and exercise. Now let's go through menopause. Besides the aromatase inhibitor, and you've got some
Yeah,
extra
forget
stuff.
that. Yeah.
Yeah. So just from menopause, that goes to 23% on average. So we triple roughly a little more than triple the amount of belly fat that we have. And it is almost universal. And so, but good news is there's definite, and that's kind of the foundation of the Galveston diet. There are nutritional things you can do to combat this. So one of my top tips for everyone, fiber, okay? You should get your fiber from food if you can. Whole foods full of fiber, your legumes, your beans, your seeds, your nuts, your berries, your leafy greens, anything with crunch has fiber. Avocado, I'm an avocado a day girl usually. And so 25 grams of fiber per day. Most women get 12 in the US.
25 grams of fiber.
Minimum
Okay.
seems to start turning the needle, where if you consistently get above 25, then you have lower visceral fat. So that kind of helps combat that inflammation. And fiber feeds the gut microbiome, keeps it healthy, keeps moving things through the colon, decreases the rate at which we absorb glucose, which keeps our insulin levels down. So that, it kind of works on multi-pronged. Foods rich in fiber are rich in a lot of other wonderful things, anthocyanins and vitamins, minerals, nutrients. So, but I recommend, okay, shoot for 25 through food. And if you have to, the benefits kind of max out about 32 grams per day for females, and great studies in longevity on decreasing Alzheimer's and brain volume with diets high in fiber. So that's kind of the top tip, focus on fiber. Make sure you're getting enough protein.
Yeah,
And so the WHI, again.
I just started, Mary Claire, focusing on how much protein I was eating because I'm 67. Again, aromatase inhibitors can affect your bone density. So I've been really trying to build up and do weight bearing exercises like Pilates, etc. And then I've been really trying to see, am I eating enough protein? And I don't know how much protein I should be eating a day.
That's a great question. So I just was on a speaking tour with Jennifer Sachek. She's a PhD nutritionist. She's amazing. And we went on and on, discussion about this. And we came to the same conclusion. WHI data, again, great data set. They looked at frailty scores, osteoporosis, and muscle strength and mass, just looked at protein intake. And women who were getting 1.3 to 1.6 grams per day had the highest, functionality scores, lower frailty scores, and better bones. So most women are getting about, and the FDA only recommends 0.8.
So what does that mean, like in practical terms?
So, divide by 2.2 and all that. So for me, I'm 100, my fighting weight is about 130 pounds. So I shoot for 100 to 120 grams of protein per day. And most women are getting 50 to 60.
So you take your weight and how do you
take my weight and I divide it. So because it's kilograms to grams, so you take your weight and you divide it by 2.2 to get your weight in kilograms. Okay. And you want to use your healthy weight. Like, what is your goal weight? You don't want to, if you have 20 pounds, so most women know what their goal weight is. I don't have to tell them. So if it's, 140 pounds or whatever, then you're going to divide that by 2.2, get your number. Then you're going to multiply that by about 1.5. And that's going to give you your grams per day. So if that's 50 kilograms, you're going to want to hit about 75 grams of protein per day. And that's how I calculate it for my patients in clinic.
And how do you get that protein? Because not all protein is probably great for you. It has sort of a risk benefit ratio, right?
So you want a varied source of protein. Animal protein is the most efficient. It's the best absorbed. It works the fastest. But if you're a vegan or vegetarian, you absolutely can hit your goals. It's just a little more hustle on your part. Most of my vegan and vegetarian patients end up supplementing with a pea protein powder or something once a day. You want to try to eat, I advise my patients to eat protein with every meal and snack, split it up and try to get at least, 25 to 30 grams, with a meal. And so, Dr. Gabrielle Lyon does a ton of work on muscle research, and Stacy Sims, they like to really hit that protein hard in the morning because everybody's working out in the morning. And that's going to help with muscle synthesis.
Okay. So that's the protein question. Mm-hmm. Okay. So I know that you're saying that the fiber can help with belly fat. Anything else?
Yeah,
I need help.
So, fiber, diets rich in vitamin D. So if you don't have a vitamin D deficiency, if you have a vitamin D deficiency, you're more likely to be inflamed and have more visceral fat. So anything you can do to lower inflammation, limiting your added sugars. So you can have cookies. You just have to,
Not
you
really. I
get a
mean, not a lot.
budget. You
Uh,
have a budget of added sugar. And if you can keep it less than 25 grams per day on average, you're going to have less visceral fat.
okay.
And so, when you choose to eat a simple carbohydrate, you want to mix it in with a fat and some protein so you can slow down the absorption of that glucose. It's all about keeping those insulin
Is
levels down.
that what the Galveston diet is kind of
Yeah,
about kind of keeping your
right.
hormones
And it's a
stable?
lot of education around naturally foods that are naturally anti-inflammatory, and some education around things that you should limit, or just enjoy occasionally due to their kind of pro-inflammatory.
Other than vitamin D, are there other supplements? For example, again, I'm all so confused. Should I be taking calcium supplements? I
No,
don't even know.
no. So calcium oral diet. So let's talk about, when we talk about supplements, we have like dietary intake of vitamins, minerals, nutrients through food. That's always the best way, right? Supplements can be helpful, but they're never going to be as good as food. Okay. And then there's other supplements that are out there that aren't like in the food supply. Things like ashwagandha, that might have some clinical benefit, very small, not great studies. So we don't really recommend those on a basis. So what do I take? I fiber supplement myself to get up to about 35 grams per day, but I hit at least 25 through food. Because for sleep, I have to protect my sleep with my life in menopause. Like even with all the HRT in the world, I just don't sleep like I used to. I can't tolerate alcohol like I used to. So
You
I
take
am taking
magnesium?
magnesium. Yeah. So I'm doing magnesium L-threonate, which is a very specific mag that crosses the blood-brain barrier probably better than the other types of mag out
And
there. There's
what's
multiple
that called
magnesium.
again for people
It's
who are listening?
there's Neuromag and Magtine are like the name brands, but the medical name is magnesium L-threonate, Threonate.
Okay. And I'll try to put that in the caption. So I
Um,
think probably a lot of people are having trouble sleeping because of hormonal changes.
yeah.
We've got my very smart followers. I always compliment them. Most of them are very smart. Some of them aren't that smart. But here, here's some here's some questions. Is it ever too late to be put on HRT? I'm 59 and told it's too late.
So
Is science changing on that?
we have, HRT is all we have the treatment of acute symptoms of menopause, the bone pain, the brain fog, the hot flashes, the night sweats, the sleep disruptions. It's always going to help with that, no matter how old you are. If you're still having symptoms, there's this myth that the symptoms will end in a year or two. No, African American women have symptoms for 11 years on average. That means some of them are going 20, 30 years. So it's always going to help with that. Okay. There's also protective benefit, but there seems to be a window of opportunity, especially for cardiovascular disease. Wonderful papers, Howard Hodis, the American Heart Association, the American Cardiology Association have all come out and said, listen, the data is clear. If you start hormone therapy in that first 10-year window of, you will have some cardiovascular protection versus women who did not start hormone therapy. Estrogen seems to be better at prevention. This is for atherosclerotic disease and heart attacks.
But wait,
It's
what is
better
that
at
10 year?
prevention than cure.
When you say that 10-year period, I don't understand. Are you saying when is
So,
that?
so within the first 10 years when your last period, so if you go through menopause at 52, you have probably till 62, to have that cardiovascular and neuroprotective benefit. After that, it doesn't mean it's harmful. It just means it's not going to be helpful, you
Well, it
know.
might be helpful with some of the symptoms of
Mhm.
menopause or post
It's
it,
always going
right?
to protect your
So if,
vagina.
let's say you're 65 and you're still having hot flashes or you're having trouble sleeping or all these other things or you have brain fog or whatever. Even though the cardiovascular benefits may not be as high or high at
Mhm.
all, is it dangerous or is it okay to be on HRT if you went through menopause 10 or 15 years
So
ago?
For those patients, what we are doing in the menopause is doing a cardiac workup. We're checking their risk for cardiovascular disease. We're looking at ApoB and the lipid profile. And a lot of our patients in my clinic, we're getting calcium cardiac scores to look for calcifications in the arteries around the heart. Once they are higher risk, the American Cardiac, Heart Association is like, we're not recommending HRT once their calcium score is elevated and puts them at high risk for cardiovascular disease. So for those
Really?
patients,
I don't understand that, because if it's preventative at a certain age, why is it a risk when you're older?
so the thought is that they feel like there's something about the estrogen that may knock some of the plaque off once the plaque is formed, and that would lead to a thrombotic event like a stroke.
Oh,
So yeah, so again, estrogen, it's protected you your whole life until menopause. And you can continue that protected benefit if you start. But once those disease processes kick in, it doesn't look like estrogen is helpful for those diseases. Now, it's always going to protect your bones, always. It's always going to protect your genital urinary system, right? So your bladder, your vagina, all the vulvar tissues, so that you don't get recurrent UTIs and vaginal dryness and pain and atrophy and all the problems that come with that.
now what about when you should stop? My mother-in-law was on HRT. She said, she felt much better on it, but I think she was worried about
Mm-hmm.
staying on it for life. I
Mm-hmm.
know you've made a joke that when you're in your casket, there's going to be a little round thing
A little
on,
patch.
on your a little estrogen patch on your body. Can you really stay on it for the rest of your life?
As this is individual clinical decision making between it. If the patient desires it, she feels like she's benefiting, and we don't have a contraindication, there is no age at which you must stop hormone therapy. You can continue, especially in the genital urinary area. We can do local therapy there forever. I mean, there's, great data. They looked at Medicaid costs, Medicare, for admissions to the hospital for urosepsis, and it's almost always women. And they said if we just did prophylactic, like give it to everyone, put it in the water, for vaginal estrogen, that we could decrease the admission rate 50% and save like billions of dollars in Medicare.
Okay.
So it's heavily protected in that area.
Somebody said, I asked my doctor about HRT, and she said if I'm getting a period, it's not right for me. Is that true?
So she's just undereducated. This is the fault of the education system and our residency programs. And full disclosure, I was a residency program director, so I know the curriculum backwards and forwards. And so we had zero training on the treatment of perimenopause. There's no reason that you cannot start hormone therapy in perimenopause. And there's great data coming out showing the mental health benefits better than the traditional antidepressants.
Wow, interesting. Is HRT safe for women with a history of aura migraines? I don't know what an aura migraine is.
So maybe migraines, headaches, right? There's a special subset of that a few women have of migraines with aura. So auras are when you have spots or dots or see floaters. It's a precursor to the headache, and it's basically because of vasospasm to the optic nerve. Okay, women who have that, who were on the old birth control pills, which were very high dose, had a higher risk of stroke when they took birth control pills. So that kind of put a black box warning for every woman with migraines with aura to never take any kind of estrogen, because you're going to have a stroke, or you could have a stroke. So, but birth control pills are much lower dose now than when that finding was, but everyone's so terrified. But, for our patients with migraine with aura, we are, if they want, and their symptoms are severe and they want to try, we'll do a very low dose patch, something transdermal, a very steady state, give them a trial and watch their symptoms very closely.
Okay. Someone asked, what is a good hormone alternative to take for someone who has dense breasts? I have dense breasts. 42% of women over the age of 40 have dense breasts. And
we need better screening. There's nothing about having a dense breast that makes you more susceptible to breast cancer. They just can't find it.
Right,
so
exactly.
This is a function of the failure of the radiologist.
I've been preaching about breast ultrasounds and MRI for women, because 50% of breast cancers in women with dense breasts are missed.
They're missed.
And it's just it's just ridiculous and unconscionable. And you have to kind of advocate for yourself. Sadly, though, it's not covered by insurance. And that's very, very
And
frustrating for a lot
we
of
need,
people.
I mean, I'm going to get political. We need legislation
I
for
know, and
this.
I've been involved in this Find It Early Act with Rosa DeLauro of Connecticut, who's one of the women who actually advocated for having women included in clinical trials in 1993. She's
Yeah.
awesome. And we're trying to get insurance companies to pay for secondary, a screening for women with dense breasts. But right now, I mean, it doesn't seem like it's going anywhere. But who knows? Maybe in the future. But what you're saying is, it's fine to.
And remember, estrogen doesn't cause breast cancer. Estrogen alone you have a decreased risk of breast cancer
Yeah.
because it's so anti-inflammatory.
But I don't understand. I'm sorry. I'm using myself as an example, so pardon me, everyone. But I was on HRT starting at like 54, and I did get breast cancer, and I
So
was.
when your cells, because you're on aromatase inhibitor, so when your cells went through their malignant transformation, so everybody starts out with healthy breast cells, and then genetics plus environment plus whatever cheese holes lined up for you to allow that malignant transformation. If your breast cell retains the estrogen receptors, which it had when it was healthy, then you are estrogen receptor positive. It doesn't mean the estrogen caused your breast cancer. It just means it retained the cell. And now we can use that receptor in treatment with aromatase inhibitors or blockers to inhibit the growth of tumor cells.
I kind of don't understand anything you just said, but that's okay. That's okay. But basically, the bottom line, Mary Claire, is that the HRT is not what caused my breast cancer. If, in fact, it wasn't estrogen. If anything, it might have been
Yeah.
progesterone.
That progestins are that seems to have been, at least in the WHI data, the bad actor was the medroxyprogesterone acetate, which we don't use anymore.
But you,
So very few, the very low association. The modern prescribing practice is to use the natural progesterone, and so, or the bioidentical, which is just called progesterone. And so there's, the data out of Europe is not showing an association with that one. Women
yeah.
get breast cancer for multiple reasons. And, fortunately for you and for others, it's caught early and treatable, and you go on to live your wonderful life. Here's my question for you, Katie. When you sat down with the oncologist and went through all your risk benefits association, did they talk to you about how your menopause was going to be managed, what your risk of cardiovascular disease would be, like what I feel like missing for the survivor population is, okay, I'm not going to have cancer again, yay, but like, how are we going to manage my bones, and the rest of my body?
Yeah. I mean, a little bit. Yes, we talked about that, but not in enough detail. That's why I was like, why shouldn't I be taking calcium and vitamin D for
So
my bone?
calcium supplements, so I kind of went off on a tangent on
Yeah,
that
that's
one,
okay.
has
If I
never been
forgot to
shown.
follow up.
So low calcium intake through food is associated with weaker bones. However, calcium supplements have not been shown to decrease the risk of fracture. Vitamin D supplements alone have not been shown to decrease the risk of fracture. And then the problem with calcium supplements, the cardiologists hate them because they feel like they'll calcify the plaques faster. And the nephrologists hate it because of the risk of kidney stones. So that is the one thing I'm like, don't supplement, fight to get it in your diet. You need calcium, but you need to get it through
And
food.
dumb
Vitamin
question.
D, hard to get it through food, really hard. Like you have to just sit there and munch on salmon all day. And so I take a vitamin D supplement.
And how much calcium through your food should you ideally get?
600 to 800 I use, yeah. Wait, that's vitamin D. Sorry.
Sorry,
My brain just went,
that's okay.
it's about
Calcium.
340, I think. I have to look that one up. Yeah.
Okay, and maybe you'll write about this because I think it would be really helpful to have a lot of this written down for people. Maybe that could be something we'll feature in the newsletter, and then I'll post it on social media as well. Um, Someone asked if HRT can cause abnormal breast tissue, which I feel like you sort of answered, and the answer is no, right?
We don't see an association with
And
that.
someone
Now,
was saying,
you can get enlargement and tenderness because we're stimulating the glands and they just get bigger. So we do see that with some patients on HRT.
okay, This is a very specific question, but I feel like this person is struggling. So I want to ask you HRT for post, I don't even know what this is,
Uh-huh.
oophorectomy at 33 years old from endo cancer and endometrial cancer?
Endometrial cancer. So she had her ovaries removed. That's the surgical term for
Oh,
removing the
okay.
ovaries. And she had a endometrial cancer. So British Medical Journal did a great study or review looking at all of the gynecologic cancers and risk of recurrence with HRT. And low stage endometrial, like a stage 1 or a 2A, there's no risk of recurrence, post-surgical treatment with HRT. It's a little trickier after. You may want to do beta-doxyphene. I mean, it's a more nuanced conversation after that with someone who's educated.
So how can this person who's struggling find the right person to advise her on what she should be
Yeah.
doing? Because I feel like not all doctors are created equal in this department.
No. And so, the Menopause Society, menopause.org, has a list of certified providers. That's still one doctor for every 33,000 women in the United States. So we have a long way to go.
Is there,
And
so how could she look up the Menopause
yeah,
Society
yeah,
and
menopause.org, they have a list of certified providers on their website.
okay, so whoever wrote that question, go to menopause.org, and if you don't have any satisfaction, DM me and I'll try to help you. A lot of people obviously are asking about weight gain. I feel like we covered that, but someone said I see a lot of GLP-1 microdosing recommendations for menopause belly.
So,
Fact or fiction?
kind of. So I prescribe GLP-1s for my patients who need them. But there's no data on no randomized controlled studies on microdosing. All of the data is done on treatment of obesity and treatment of diabetes. And so that is where we have discussions with our patient. It works. I mean, so when I come in to my practice, we do, have a background in nutrition. We have a long discussion on HRT, risk, benefits, are blah, blah, blah. We do a massive amount of blood work. We're looking for nutritional deficiencies, all the things, right? And then we make a decision. I bring her back and we do a body scan. So I have a scanner where I'm looking at muscle mass, visceral fat, I'm trying to give her body composition, right? So we know what we're working with visceral fat. So then we do the nutritional changes first. Okay. Come back, see how she's doing. Then we have the discussion about adding a GLP-1 and if that would be right for her. There's no microdosing. We give the standard doses like we would any patient with obesity. Now, microdosing, I don't, that's not really a medically defined term, but I do think GLP-1, here's the deal, and this is what excites people. When there was a great study looking at GLP-1 plus HRT in women versus GLP-1, and these patients were diabetics, okay, and obese. And they lost 30% more weight when you combine the two versus GLP-1 alone.
Oh,
Mm-hmm.
interesting. Okay. Sounds like that's kind of very new research, though, and kind of still being figured out. We're going to have to do this again because there's so many questions. And seriously, I got like, gosh, 95 questions. But Junie Locks, hello, Junie Locks. How do I know what HRT is right for me? My friend has pellets inserted, bioidentical. Another friend does the patch while another has a cream. I'm so confused.
That's right. And I get confused too. So bioidentical just means identical to what your ovaries made. And that just throw those terms out. That is estradiol, progesterone, and testosterone, just like that. Okay. There are great, efficacious, safe, affordable, FDA approved options for bioidentical hormone therapy. Okay. The estradiol patch, the estradiol pill.
I
There's
was
a
on the estradiol patch.
patch. Yeah. I'm on the patch. So the spray, there's a vaginal ring. There's all kind of ways to get it in your body. The pellets, I think you can do better. They're a big money maker for a lot of practices, and there's some ethical issues there. They're really hard to get steady state dosing, and I've just seen a lot of problems with them.
I wouldn't want that. I
And
wouldn't want them
and
in my
once
skin.
they're in, you're stuck for for 3 to 4 months. They tend to overdose the patients. Not all doctors, but I just feel like you have better options than that, and you don't have to go outside of an FDA approved option. I love having compounding options. Not everything works for everyone, but my go-to is going to be estradiol patch, oral micronized progesterone, and the T-stem gel or the androgel
Yeah, a lot
for
of people
testosterone.
are asking and about testosterone. They're
So
saying, how do you know
it's
when you
not
have the,
FDA approved for women, and that's a problem. It should be, because we have great data showing for HSDD, hypoactive sexual desire disorder, it works amazingly well. There are two FDA approved medications for that work at the melanocortin or at the neuroreceptors, Addie and Vyleesi. But testosterone, in a postmenopausal woman who had a good libido, loves her partner, misses it, if you don't care if you ever have sex again, excuse my language, then okay, but these are women who this is distressing them. And testosterone seems to be really helpful. Clinically, we're seeing women on testosterone have better stamina, they're having better workouts, they're having, as long as they stay in a physiological range. Now, you give someone too much testosterone, she will start losing hair, she will grow hair in places she doesn't want it. You have clitoromegaly, voice changes. So we're really careful to monitor these patients to make sure they're not getting super physiologic.
wow, I'm telling you, I've never seen so many questions for an Instagram live, which, as I said earlier, just shows
I mean,
there's
that's
such a
why I
need.
think I blew up on social, Katie, because I'm just answering questions all day. I mean,
Yeah, no, I'm sure. And I feel bad because people, they want to live well and feel good and be healthy. And some of these things are really disruptive to doing that. Um, what I'm going to do is, if it's okay with you, Mary Claire, do another Instagram live, maybe in a week or so. I'll get the questions that we didn't get. Hopefully people can watch this. I'd like to ask a selfish question only because I think I'm not the only one out there. I feel like my joints hurt all the time. I don't know whether it's because I had to stop my estrogen replacement therapy or my hormone replacement therapy. And, when I was diagnosed with breast cancer, but I feel like I never had sore joints, and sometimes I feel like it's hard to pick things
mhm.
up off the ground, and it's really frustrating for me. And I feel like I'm 108 years old
So there's
sometimes.
a paper that just got published a week or two ago called The Musculoskeletal Syndrome of Menopause. And estrogen is incredibly protective of our joints, incredible.
So what do I do
And
since I can't take it?
arthritis, arthralgia. So again, more research in SERMs. There maybe a little testosterone might be helpful. I mean, there's, finding a provider who can kind of work with you, explore your options. The paper is excellent. She's the author of that paper is coming out with a book called Unbreakable. She's an orthopedic surgeon, has devoted her life to taking care of women in the prevention of osteoporosis and arthritis
I have
associated with menopause.
osteopenia, which I
Mhm.
guess is the precursor. And that's one of the reasons I've tried to eat more protein and do more weight bearing
Did you
exercises.
get a weighted vest?
I
I'm
got
a big
a
fan.
weighted vest. I just did, and I haven't really used it, but I have it. And, when it's less hot, I think I'm going to try to use
Mhm.
it more. I'm really trying to do all the right things. I play a ton of pickleball. I don't think that's weight bearing, but at least gets me moving,
You're
right?
getting out there.
Yeah, and I'm trying to lift weights
Hmm.
too, but my joints really do hurt, and it's a major drag.
Yeah. Now, there's, an anti-inflammatory diet, avoiding the attitude, all the things you can do to lower that inflammation naturally through your diet is going to be key. There, there's two or three studies that looked at turmeric supplementation. Again, you don't want to overdose on it, but on arthritic pain and joint pain in menopausal women, and the turmeric study looked fairly promising.
But
So,
can you take those as supplements, or should I be getting actual turmeric and using it?
in the studies, they use supplements because they're easier to control. Turmeric in its natural form has a very low bioavailability. It's really hard for the gut to absorb it. It kind
Oh.
of just passes through. So in the supplements, it's usually combined with piperine, which is a black pepper extract to
Oh,
increase the
right.
absorption.
Interesting. Well, again, I'm so excited that you're going to be part of our community, Mary Claire. I think it's, as I said, there's a real need for people like you to take the time and help people understand what's going on with their body and how they can feel better. And let's
We
do it
have
again soon.
So we on our website at thepauselife.com, I have a ton of free resources, blogs. I go through HRT options. We have downloadables, all free, for your followers who want to go and learn more and just poke around the website and see what they can find. There's a little search bar. You can just type in a term and we probably have a blog about it.
That's great. And maybe we could also post some of that on our website so that, people can find it easily. when they're looking for it or they're looking at other stuff that we're featuring. Mary Claire, you're so great and such a good communicator,
Thank you.
and everyone who's watching, we'll do this again soon. And I'll try to get to more questions next time. But
Awesome.
Mary Claire's got to go, and I actually have to go too.
Okay.
All right. Thanks, Mary Claire. Talk to you soon. Bye,
Bye.
everybody. Bye.